just to talk about IVC in terms of technique, here you can see my beautiful animation of an aorta and an IVC. First steps first, you're going to put your probe right in the middle of their abdomen if you're trying to do a transverse view, which is going to give you this kind of nice image. More importantly, I would say, is getting the longitudinal. So what you typically want to do is move your probe over to getting that IVC right in the middle of your transverse image, and then rotate 90 degrees, which is then going to, allow you to see that classic smiley face. So what's our normal look like? It looks like a happy whale, right? So there's your happy whale. Kids love seeing it. A lot of kids like doing it, on themselves. And so when you see that happy whale, the big thing I always tell folks when you're doing it is try and look to see, just to be clear to yourself that that's exactly what you're seeing, that it is leading into that right atrium. So tilting your probe up and seeing that you're entering the heart there is basically anatomically telling you that you're definitely looking at the IVC. Because some people, I don't think it happens that often, but can be misled by the aorta, which you're not going to be seeing that kind of property with. All right, so what are we seeing here?
Very collapsed.
Collapsed.
Yeah, very collapsed
IVC.
IVC. So we have this thing that we call the Caval index, which has been studied at some length, which is basically evaluating the IVC size 2 centimeters from the junction with the RA. And the Caval index is really a sort of formula that says maximum diameter minus minimum diameter divided by the maximum diameter. So it really gives you that kind of percentage that you're looking for. The problem we have with these percentage determinations is that we don't really know what the normals are, particularly for kids, and it can be quite variable with respiratory mechanics. And so things like the Caval index have not really been shown to be too predictive of giving us, an evidence for fluid responsiveness. So most of us who are doing this on a regular basis are not typically measuring a whole lot of stuff. And so, while it's important to maybe know that these things exist, and maybe in the future we'll determine some valid way of using them clinically, we just haven't seen that on a day-to-day basis that Caval index and these sorts of things are going to be changing how you approach a patient beyond you qualitatively looking at an image like this and saying, yeah, that IVC looks pretty underfilled. Compare that to now this one, and what are we kind of seeing here? Plethoric. So when you say plethoric, what tells you that?
There's no variation with the respiratory side.
Right. So no respiratory variation at all. Presumably this patient is breathing, and we're basically just seeing this like barrel. And then you're also just getting engorgement of those secondary hepatic veins, right? So much thicker than you're sort of typically seeing. Very happy IVC, but not a very happy patient, presumably. Okay. So just to point out a few things, I'll just skip over that one, but if you do love measuring things, the measurement that we'll typically talk about in terms of another determination beyond Caval index will be the IVC aorta ratio. So if you're measuring the IVC, and you typically want to do this in a transverse fashion so that you're not capturing the sort of side of the barrel, as it were, because if you're looking at it from a longitudinal angle, you may be sort of slightly off axis and slightly under measuring something. But typically you're going to measure this in a transverse. The ratio we talk about is 0.8, and below would be suggestive of hypovolemia. Now you guys did the journal or the chapter today, and what you should probably get out of that is that the sensitivity is very high for this, meaning that probably most people who are dehydrated are going to have an IVC over aorta ratio less than 0.8, who are profoundly dehydrated, but the specificity is not so good. It's like 50 to 60%. So what does that mean? Well, it means that there's a lot of kids who are not dehydrated that are going to have an IVC aorta ratio less than 0.8. And so with that, it kind of becomes hard to know, what do you do with that information, right? So you've got a small IVC aorta ratio. Does that mean they need fluid? Does that mean that they're going to respond to fluid? Those answers are probably hard to determine because you're lumping in a lot of patients who have dehydration with a lot that don't. And so then we think about, well, why is that? Why isn't it just that, there's this cutoff we can set? And it probably has a lot to do with the next slide, which is on respiratory mechanics. So a lot of our patients have more than just, dehydration issues. They have breathing issues. And so as they breathe, they do what? They create this negative intrathoracic pressure. That negative intrathoracic pressure is transmitted to their IVC, which causes your IVC, as compared to your abdomen, to be relatively negative, and your abdomen to be conversely relatively positive to that. Because that's outside of the thorax and you're not sort of equalizing those pressures, what's that's going to do? Well, it's going to cause your actual IVC to collapse. And so in patients who are breathing heavily, whether that's because they have a respiratory issue, or they have a fever and they're just breathing very fast, or they're afraid, or whatever the situation might be, it's going to cause your IVC to look relatively smaller in comparison. And there's going to be a lot of kind of measurement sort of challenges in those situations. On the flip side, if someone's actually getting positive pressure ventilation, so they're either getting CPAP or they're getting a intubation, it's going to do the exact opposite, right? So now you're putting positive pressure into the thorax, which is going to cause your IVC to look relatively enlarged compared to your abdomen. And so just keeping in mind some of these kind of factors is going to help you determine whether what you're looking at with the IVC is something that's clinically relevant. So it's got to be taken within the context of what's happening with your patient. Take-home points for the IVC: identify it in the aorta in transverse, and that's going to help you guide your longitudinal view. Most of us now probably don't even look in transverse in many cases because it's relatively easy to see in longitudinal still, but if you're trying to guide a novice to be sure about how they're finding it, it probably does help to look in transverse first and then spin the probe when you're directly over it. Appreciate the effects of respiratory mechanics. You could probably talk about a whole lecture in terms of the IVC and the evidence that's been done there. And I think Leanne already had sent you guys those top 10 reasons why the IVC can be unreliable. Look for variability with respiration as well as backup with increased pressure to the hepatic vessels to kind of guide that, is this kid plethoric? But keep in mind that, them doing some of the things that you'll read about in the adult literature, like the sniffing test to look for your, 50% or more than 50% kind of thing, is a lot dictated by the compliance of your patient and their ability to follow instructions. Not something we get a lot of the time for kids. So quickly on B-lines now. So the one thing we can say is that while ultrasound and X-ray are, often juxtaposed with each other, this is one area where strangely we agree on. So these are curly B-lines. So apparently we've also determined B-lines in ultrasound, and they actually typically represent a very similar phenomenon. So with B-lines, you can see them, of course, with any probe, and certainly if you're in a resuscitation, you may well still be using your deeper probes. So don't feel like you have to go to your high-frequency transducer, though probably, with everything else, chest ultrasound using a linear probe is going to be a better way of assessing that area. So a normal lung is going to kind of look like this, of course, with your A-lines, which are those horizontal lines coming down throughout the screen, and these kind of little tiny ants marching. Now, I've heard that some people will call comet tails B-lines, and whether comet tails are B-lines or comet tails are these little ants marching things. I'm not sure what the right answer there is, but certainly you'll see those little kind of streaky guys coming every now and again. You will actually see more of those in younger kids as well as kids who have viral kind of infections going on. And we don't consider those B-lines, as opposed to this image, which now will show you these kind of classic B-lines, which are like those spotlight projections. A lot of people get tripped up by some of the terminology initially. So whether we should still be talking about A-lines, B-lines, and those sorts of things, I don't know. But the thing that we're looking for as pathology would be that kind of spotlight thing. So that might be more kind of apt for a novice to kind of understand what they're looking for, as opposed to those little comet tail, stringy kind of things that are coming down, which are not typically felt to be pathological.